Hi, my name is Gaston Marquez, and today I will present our research called Evaluating Dissemination and Implementation Strategies to Develop Clinical Software. The structure of my presentation is described in this slide. First, I will talk about the context, then I will show the DI framework, then I will describe the case study, and I will conclude my presentation with the corresponding key findings. The context of our research is software requirements to develop clinical software. The software requirements are description of features and functionalities of the target systems. Requirements convey the expectation of the user from the software product. Software products, on the other hand, have been helpful in supporting management and productivity in several economic sectors, including healthcare. Indeed, clinical software is committed to develop a secure, efficient, and innovative clinical application and laboratory instrumentation system. Much of daily clinical work is supported by software that bridges separate clinical processes, sub-processes, activities, and others from healthcare management to more specialized procedures, such as surgeries. To develop clinical software, developers must often face several challenges, and one of these most important challenges is the understanding of the real clinical problem that the software must address. The consequence of incorrect requirement elicitation can be extrapolated from clinicians' rejection to poor software development management. On the other hand, several studies have established that incorrect requirement elicitation causes the clinical software to fail to satisfy clinician and stakeholder expectations, thus leading to a rejection of new technologies in clinical processes. This presentation describes a study about the perception of clinicians regarding the event management system called CGCAM, was software requirements were elicited and defined using a specific technique called DI framework, which I will explain in the following slides. In this study also we focused on evaluating CGCAM's functionalities and types based on the usability expectation levels of clinicians using a specific questionnaire called Health Issues. Now I will describe the DI framework. The DI framework uses implementation and dissemination strategies to recommend requirement elicitation guidelines that support clinical software developers in the identification of requirements in the health system. The novelty of this framework is related to the use of dissemination and implementation strategies that define methods that translate clinical research into practice. The conceptual idea of the DI framework is based on implementation and dissemination science. Dissemination science drives the adoption of clinical intervention for deployment in practice through the use of dissemination agents who work hand in hand with practice-based agents to choose, adapt, and implement evidence-based programs. Implementation science, on the other hand, is concerned with studying the adoption of clinical intervention supported by specific evidence by providers and health systems, aiming to bring evidence-based medicine into evidence-based practice. For example, these two categories of implementation are supported by specific strategies that can provide guidelines for eliciting requirements in a clinical context. The framework considers four stages. First, the identification of project stakeholder, then the identification of clinical priorities, then the collaborative selection and implementation strategies, and then the corresponding analysis of all the information collected from the framework, the DI framework. Now I will describe the case study conducted in this research. The context of this case study is bed management. Bed management corresponds to a strategic support unit within clinical institutions that allows for estimation of bed resources and the transfer of patients according to the care they require. And one of the most important critical restrictions when treating patients or being able to respond to different treatments is the number and use of beds. So, to support the management of clinical beds in the Chilean health network, we have developed an intelligent system for the management and analysis of bed allocation called CGCAM. This system allows systematizing people's hospitalization in health centers of low, medium, or high complexity. During the development of CGCAM, the DI framework supported the developers in the process of elicitation and description of requirements. Initially, developers used the framework to start requirements. In turn, the information acquired in previous releases was used to improve the requirements analysis. Although we know that the DI framework has supported the CGCAM development team in each release, we realize that it isn't clear if the end users perceive such improvements in the system. So the main goal of our case study is analyze the functionalities and tags of CGCAM from the purpose of evaluating the impact of using the GI framework with respect to the elicitation and description of software requirements from the point of view of clinicians in the context of PIP managers. Subsequently, the result question of this case study is there a difference in the clinician perception about CGCAM's functionalities and tags regarding the first release and the last one? So in this case study, we use the four main models of the system, which are described in the right hand on the slides. On the other hand, given that the system is used by many professionals with different profiles, we select the most critical profile of the system. So the subjects participating in this case study correspond to emergency nurses, floor nurses, med manager, and service directors. About the data collection, as I said in the previous slide, we use a specific questionnaire called health issues. This instrument is a questionnaire based on 4 factors, which are as follows: quality of work life, perceived usefulness, perceived ease of the use, and user control. So you can see in the right hand of the slide, you will see the questionnaire adapted to this case study. The goal of the questionnaire is to measure the relationship between users and the system tags in a specific setting. About the analysis, we compare the responses of this questionnaire carried out in 2 years, 2018 and 2020. And to analyze the answer to both questionnaires, we use the descriptive statistics. So we first calculate the average of the answer for each question of the questionnaire, then we compared the average of the answer of each question in both questionnaires, and finally we determine whether there is a difference between the questionnaire average using the t-test. So as a result, this figure compared the average of the answer to each question of the health issues questionnaire carried out in 2018 and 2020. For instance, you can see here that in question A1, the average in 2018 was 3.1 and in 2020 was 3.46. We realized also that the result of the t-test showed that the value of the difference between the answer is significant. So we can establish that there is an important difference between the different answers of each questionnaire result. So according to the result described in the previous slide, the overall average of the survey carried out in 2018 was 2.91. And the survey carried out in 2020 was 3.25. In addition, we realized that there is a significant difference in the response of the questionnaires. So the study results show a better perception of clinicians regarding the functionalities and tags implemented in CGCAM compared in these 2 years. About the first release of the system, the developer appreciated the guidelines proposed by the GI framework to release the requirement. So we know that these preliminary results do not allow to bridge the requirement elicitation using the GI framework with the result of the health issues questionnaire, but we can interpret the result of the questionnaire from the point of view of the CGCAM developers and the feedback of the clinicians. So the feedback from CGCAM developers and the study result reveals that the implementation and the dissemination strategy help intervene in challenging and rapidly changing contexts. We also realized that the framework also helped to detect whether there are unintended consequences to implement some strategy, and hence to the elicitation of requirements. So the conclusion, in this presentation, I described a study that evaluated the functionality and tags of a bed management system called CGCAM from the point of view of clinicians. So the identification and description of this functionality and tags were conducted using the GI framework. The result of the study indicated that clinicians perceived an improvement in the system. So to further our research, the context evolution of the coronavirus has forced the system to be constantly improved in order to allocate beds to critical systems. So we want to study whether the GI framework helped developers implement new functionalities in CGCAM under the constant pressure of changing requirements due to the coronavirus. So thank you very much for your time.
All right, we're live.
Okay.
Thank you, Gaston, for this great presentation. A very interesting research, and the final paper in our session on requirements engineering. Now, I want to start off with a few questions, and I will see what comes in from the audience as well.
Okay.
So I was wondering that my first question was about the bad management case study, the bad management system. I think on one of the slides during the presentation, you talk about an automatic or fully automatic system. I was wondering, is that really the case? Is this system fully automatic, or is there some sort of a human intervention or human control about it too?
Well, the system is fully automatic right now. We are using several algorithms to try to create this connection between bed management and clinical service. We are using right now optimization algorithms, and we are using also machine learning techniques in order to create recommendation of beds or try to give all the data from patient in beds in order to create more sophisticated analysis of right now in this moment to try to select more critical patients in order to use that bed in when they have, for example, COVID-19.
Right. Yeah. So related to that, as a follow-up question, then, and I have to say, I was a little surprised then, if it's fully automatic, in particular in situations where clinical decisions aren't maybe necessary, where you really have to potentially have, in my understanding, a doctor making a decision, okay, well, this person here is more critical than this other person, and we only have one bed left in the ICU, in the intensive care unit. So I'm making that decision that that person has priority. If you make that fully automatic, you almost have to have a very sophisticated clinical decision making system there. Is that really something like that your system can do?
No, the system only gave information to make the decision to the clinical professionals. The clinical professional has the whole thinking about which patient have to use that bed. We only get data to try to make that decision. So the system take information from all the beds, try to condensate in a dashboard. Medical professionals or physicians try to understand that information, see the graph, for example, and they make the decision in order to try to achieve and trying to care of the patient with COVID. The system don't have the functionalities to create automatic response or try to make decisions. It only is a help, a support for the professional.
Okay, so it's not directly changing assignments and saying, okay, now this person leaves this bed and goes to another unit.
No, that's impossible. That's impossible because the system is only a support for condensate information, try to manage information. But the decision, the medical decision, is made by professionals, not by the system.
Yeah. Okay. That makes a lot of sense. Thank you for clarifying. Now, I wasn't quite sure whether I could read the presentation. It was a little fine print, but I think you talked about dissemination science, right, as being the one of the foundations for your approach. And I'm not so familiar with dissemination science. I am more familiar with action research, which I don't know if you can contrast this. It sounds that similar ideas go into this, that this notion of evidence-based, getting feedback from releases and putting that back into the design of better versions of the release for next time, and then getting that evidence back and so on. Is there some sort of a connection between dissemination science and action research?
Yeah, I mean, dissemination science and dissemination implementation science provide guidelines to try to connect the innovation practice into clinical practice. So our biggest issue here is try to capture requirements in order to create the system. So the first issue here was to try to understand how clinicians think about what the system wants.
So we decided to use this guideline because this guideline describe practice, recommendations to, for example, create workshops in order to try to capture information from different perspectives, different stakeholders. So using all the requirement elicitation techniques, plus considering this implementation and implementation dissemination guidelines, we create requirements with elicitation document that is more accurate and more precise and more realistic in order to develop this system. So this is our first experience using these guidelines. We have good results, and for example, we are using the same guidelines in order to replicate the system in other hospitals in Chile. We are actually now we are exploring these guidelines in order to try to modify them and incorporate more in the corpus of software requirement elicitation.
That sounds good. One question I had when you were evaluating the approach, and you had this question about what's the impact of the DI method on the particular case study. You had this question about do clinicians perceive a difference between the releases, and do they feel that the releases are better or become better that you evaluate with your questionnaire? If somebody asks you saying, well, you know, you could have used a different method, and probably they usually software becomes better over time. Well, actually, it's not usual. Sometimes it also gets worse over time. But do you have how would you respond to somebody saying, well, usually we learn as we go, and bugs are removed in subsequent releases, and usually people are more happy with later releases anyway, so it doesn't really show that your method actually is potentially then more suitable than another requirements engineering method? How would you respond to that?
Well, basically, the method was very useful for us because the method recommends guidelines in order to understand first the clinical process that we have to address. For example, in this case of management, implementation strategies show us recommendation about, for example, how to understand the clinical process that contains bed management in that hospital. So, for example, we have to interview the nurses, the clinical doctors, administrative people, and so on. So, understanding the clinical process, we could capture more requirements than using maybe some classical techniques. So, for example, I am not clinician, but I could understand how the bed management process in that hospital works. So I can understand the beginning of the end. So all the activities recommended by implementation strategy help us to expand the knowledge about how to understand the different perspectives from clinical work in order to capture more data, more information to define the requirements that we implement. So when we develop the system and we release the system to production, we realized that the people who use the system were very familiar with the system. They say, okay, this is easy for me because this functionality connects to this service, and this service sends me this Excel file, and with the Excel file, I can see the patient when using bed. So until now, we have small issues related to the infrastructure, but about the functionality is working fine. So that was the decision to execute this questionnaire of usability questionnaire in order to know how the people that use the system is perceiving the benefits of the system. So according to our result, we get very good result, and we are very happy for that. But we know that we have to still working, we have to still understand the process, because understand the clinical process is not trivial. It's very, very complex. And if we want to create a software that resolves problems in that services, we have to first understand that new word for us. So dissemination implementation strategies help us to understand that.
Super. I think we have room for one more question, potentially, and 2 minutes here on the clock. And pose it since I don't see anybody else in the chat right now. So I'm interested in potentially how to deal with re-engineering of maybe existing systems, where you're not developing a new system for example, the bad management, but let's say there is an existing system in place and we're trying to make it better. Do you think your method would work for something that's pre-existing as well, to making it better, to re-engineering, rather than greenfield development? Greenfield meaning that you develop something from scratch where everything's manual before you start.
Yeah, sure, because when we conduct these activities with the stakeholders of the system, we realize that we're getting more information than we want. For example, we can get architectural decisions, stakeholder perspective, critical functionalities in the system. So if we can use all the data, all the information, and apply re-engineering for that, we can create more precise models about the system that we are working in that moment. So I think if we can complement this perspective of implementation and dissemination strategies in that process of re-engineering, we can obtain more data about more information about the system, of course.
Thank you very much, Gaston.
Thank you.
We're pretty much at the end. 15 seconds left on the air here. Let me thank you on behalf of all of the organizers and the audience again for your contribution. Great presentation. If you wanted to check maybe the discussion room as well, if there's